Welcome to this explainer. All right, let's just dive right into it. Today we're taking those incredibly dense textbook anatomical tables and turning them into a clean, visually structured clinical roadmap. Imagine you're a surgeon. Your literal job is to operate around some of the most delicate, vital structures in the human body, nerves and blood vessels that are completely hidden from the naked eye. So how on earth do you pull that off without causing catastrophic damage? Well, we're going to look at the exact evidence and anatomical blueprints that make this possible. We're using a super clean clinical approach to map the unseen.
Which brings us straight to our core clinical question for today. How do clinicians accurately estimate unseen spinal and cranial structures during navigation? It's a skill that is absolutely essential for safe procedures. You obviously can't just guess where the spinal cord or a major cranial nerve is, right? You need a rock-solid, evidence-based system to predict exactly what lies beneath the surface, way before you ever make a single incision or insert a needle.
To figure this all out, we're taking a macro to micro journey today. We'll start broad with the clinical challenge, then look at spinal landmarks and cranial foramina, and finally zoom all the way down into the microscopic anatomy of the auditory canal and its specific nerves, before wrapping up with our key clinical takeaways. Starting off with Section 1, the clinical challenge. We really have to establish why mapping this anatomy is so absolutely critical before any physical intervention even begins. The thing is, the human body doesn't come with coordinate grids drawn on the skin. To maneuver safely, clinicians have to rely on surface estimates to predict deep structures. It's kind of like forming a biological GPS. By identifying, say, a bony prominence or a specific cartilage on the outside, a clinician can confidently triangulate the position of the unseen anatomy on the inside. That right there is the absolute foundation of anatomical precision.
Moving right along to our first level of evidence, let's hit Section 2, Spinal Landmarks, where we'll examine the macro surface anatomy of the neck and spine.
It's actually kind of mind-blowing how neatly these anatomical relationships line up. Looking at the clinical evidence from our source material here, we can anchor ourselves using very specific touchable points on the neck. For instance, in anterior cervical spine surgery, you can feel the angle of the jaw, the mandible, to estimate the C1 to C2 level. As you move down, feeling the thyroid cartilage puts you right at C4, C5, and locating the cricoid cartilage tells you you're right at that C6, C7 level. It's quite literally a roadmap you can trace with your fingers.
Let's travel further down the back to see how this system builds. Contrasting those upper regions, the scapula, your shoulder blade, helps estimate the thoracic levels. The spine of the scapula sits at about T2, T3, while its inferior pole rests way down around T6. And down in the lumbar region, we use what's called the intercristal line. If you were to draw an imaginary line between the highest points of the iliac crests straight across a patient's back, it's going to cross the midline exactly at the L4-L5 interspace, or right on the L4 spinous process itself. This is incredibly vital for getting procedures like lumbar punctures exactly right.
Now let's travel superiorly, all the way up to the skull base. For Section 3, cranial foramina. This is where we encounter the complex, hidden passageways that protect our vital nervous system.
The sheer density of the cranial foramina here is honestly staggering. You see, the skull base isn't just solid bone. It's riddled with very specific holes called foramina, and these act as incredibly strict gatekeepers for neurovascular bundles. Just think about the massive amount of anatomy packed into this tiny area. Every single artery, vein, and cranial nerve literally has to thread through a highly specific bony channel to exit the brain and reach the rest of your body.
If we distill that dense evidence down, we can really highlight a few vital pathways. The optic canal, for example, is the exclusive home to cranial nerve 2 and the ophthalmic artery. Then you've got the jugular foramen, which is basically a biological rush hour. It's incredibly crowded, containing cranial nerves 9, 10, and 11, plus the internal jugular vein. And the foramen magnum? That's the largest opening, protecting the spinal cord itself along with cranial nerve 11 as it enters the skull. This brilliantly illustrates how these specific foramina act as absolute critical checkpoints. If there's any swelling or a tumor near these exact locations, well, you know precisely which bodily functions are going to be compromised.
All right, having looked at the macrospine and the mesolevel skull base, let's zoom in even further for Section 4, auditory canal anatomy. We are going right down to the microscopic level of the inner ear. We're focusing right in on the porus acousticus, also known as the internal auditory canal. The architecture here is just incredibly precise. The canal is divided into these tiny quadrants by delicate crests of bone. A horizontal line, called the transverse crest, divides the top from the bottom. Then there's a tiny vertical crest, which is famously known as Bill's bar, named after Dr. William House, and that separates the front from the back. Notably,
Bill's bar sits a bit deeper in the canal than the transverse crest.
Looking at the spatial layout here, you can really see how this mechanism works so brilliantly. Notice how that vertical crest, Bill's bar, safely isolates the facial canal anteriorly from the superior vestibular area posteriorly. And the transverse crest, running right across the middle, separates those top structures from the inferior vestibular area and the cochlear area below. Literally, this tiny bony grid is the only thing keeping these incredibly delicate nerves neatly organized.
Which leads us perfectly into Section 5, the 5 IAC nerves. Let's find out what exactly is traveling through those 4 tiny quadrants.
Housed inside these highly specific quadrants are 5 distinct nerve branches that clinicians must absolutely commit to memory. Our source material gives us a super detailed breakdown. We have the facial nerve, cranial nerve 7, along with its sensory branch, the nervus intermedius. Then we've got the acoustic portion of cranial nerve 8, right alongside the superior and inferior branches of the vestibular nerve, and each of these terminates in very specific semicircular canals and structures of the inner ear. Now, in the high-pressure environment of an operating room, surgeons need absolutely foolproof ways to remember this microanatomy. Interestingly, the source reveals they actually rely on everyday brands for life-saving mnemonics. First, 7-Up. This tells us that cranial nerve 7, the facial nerve, is located up in the top or superior portion of the canal. Next is Coke Down, reminding us that the cochlear portion of nerve 8 drops down into the inferior area. Finally, LSU, which elegantly maps out that the superior vestibular branch connects to the lateral and superior semicircular canals and the utrobal. Honestly, it's a brilliantly simple system for some incredibly complex biology.
Let's bring it all together and summarize our clinical roadmap in Section 6, Clinical Takeaways. We've covered a lot of ground today, from the neck down to the lower back, and all the way up into the inner ear.
Let's consolidate everything we've learned today into a few key points. The absolute crucial takeaway is this: safely navigating the human body relies on a tiered system of knowledge. Surface markers provide our macro estimates, right? They let us find things like the C6 vertebrae using the carotid tubercle. Then, the cranial foramina act as our meso-level checkpoints, dictating exactly where those neurovascular bundles enter and exit. And finally, those robust mnemonics decode the microanatomy, ensuring safe spatial navigation when you're dealing with literal millimeters of space in the auditory canal.
But before we wrap up, we really have to acknowledge a critical limitation here. Are these biological estimates foolproof? Well, the answer is no. Because human anatomy naturally varies a bit from person to person, these surface landmarks like the angle of the mandible or that intercrystal line we talked about are ultimately just incredibly educated estimates. This is exactly why the source text explicitly states that intraoperative C-spine x-rays are always essential to verify your position. Which leads us with a provocative final thought for today. If our physical anatomy is as unique as a fingerprint, how might advanced imaging entirely replace these manual biological estimates in the operating rooms of the future? Thanks so much for joining me on this explainer. Keep learning and always keep questioning the evidence.